Good morning, everyone. For those of you that don't know me, I'm Valeria Gal. I'm the project lead with the QI team at the BC Center for Excellence in HIV/AIDS. I'm joined today by Angie Semple, who's our QI project coordinator working on the Boost Collaborative, as well as Cole Stanley and Sharon Vippler, our medical consultants that should be joining shortly. And we are very pleased to have Clemens Steinbock, a QI consultant, here with us today to present a new QI tool. So before we get started, I just want to mention that the session is being recorded for educational purposes. If you have any concern with this, just send a message directly to Angie. And the session will be posted on the Boost Collaborative website later this week or early next week. So look out for an email on the listserv. So if anyone you know that was interested in attending this but wasn't able to, they'll be able to access that on our website. So before we get started, I want to begin by acknowledging that the land on which we gather is the unceded territory of the Coast Salish peoples. Also, a quick overview of Zoom. I'm sure by now everyone's quite familiar with it. We will have everyone muted during the presentation. If at any point you have any questions or comments, feel free to type them in the chat, which is a box just on the bottom of your screen. You could also raise your hand if you want to unmute yourself and ask directly. I'll let Clemens comment on how he wants to manage those during his presentation. And at the top, there should also be a view option tab where you can annotate. Sometimes during the presentation, there may be opportunity for that. So that is where that button is. If anyone is having any issues hearing me or with the sound, please just type it in the chat and one of us will connect with you to sort things out. I guess I should have done that at the beginning. I'm going to assume everyone can hear me. All right. We just want to take a moment to thank all of the funders and sponsors for the Boost QI Network, Health Canada SUOP program, the BC Center for Excellence in HIV/AIDS, Shared Care, and all our health authority partners, as well as patient and family voices. So I'm now going to turn it over to Clemens, who is familiar with many of you that have been involved with Boost in the past. He was involved with the provincial Boost and the Vancouver Boost as a QI consultant, where he attended many of our in-person events. And so I'll turn it over to him and I'll let him take us away.
Thank you so much, and thank you, Valeria and your team for, I'm glad to be here with you. I hope you hear me well. Everybody give me a thumbs up. Okay, awesome. So it's glad to be back after a little bit of time. I was, Valeria and others kept me informed about the many wonderful things that you're doing. So I'm glad to be back to talk today a little bit more about the driver diagrams and how we can use it in quality improvement. First, let me start out by putting into the chat room, maybe you can put your first, last name in the chat and also a number. I want to know how much you know about driver diagrams. So I'm Clemens Steinbock, and I put this in my chat in a second. And I will rate myself as probably closer to a 4 or 5. So I know how to use driver diagrams. I use them and train others. So if you're unfamiliar with it, then you probably need to put it closer to a 1. It is okay if you don't know much about it, but it gives me a little bit of a sense, where are you? So to adjust the pace of learning to your needs. I'll give everybody a second to type in. So what you want you to do is first, last name, the agency if you can, and then also the number. Give everybody a second to do. If you have, I see the Hope to Health Clinic, I love your name. There is, if you have multiple people, so make a consensus in terms of the score. Okay. I see some of them coming in. Okay. That's great. Thank you so much. Okay, that helped me quite a bit. How about this? Keep typing. I'm just getting started. I also want to express hi Cole, good to have you. Okay, I'm going to share my screen now. I'm going to go through the slides. The slides are available afterwards. We're happy to share them. Please use them. If you feel that could be helpful to others, I would strongly encourage you to use them. Let me just clean up my screen a little bit here, get the chat room going so I can know a little bit who else has entered the room. Okay. So we did a quick round of introductions. It was really helpful to hear from you. Appreciate it. So what are we trying to do here today? What we're trying to do here is to learn a little bit more what is a triad diagram and understand a little bit the core components. Particularly, we want to learn today is about what is the really the use in quality improvement. And I'll go even further to say, so how can we practice the use? And I came up with some basic examples to play with. But then more importantly, I want to show you some examples that I had the pleasure to work with the Institute of Healthcare Improvement with IHI and to develop some of them. And I want to show you one tool related to substance use that we developed with them. And I really hope that this ultimately will make a lot of sense to you intuitively, and I hope that you can really use it going forward. Let's do this again. We're using the chat room, so you just many of you have used it before. So what I want you to do is to put in the chat room one thing you want to improve, whether it's work, COVID related, work stress, or personally. You know, all the COVID and getting more exercise or anything you want. And I also want you to put in 2 or 3 things of steps that you want to take to achieve that goal. Again, enter one goal, aim, one thing that you want to improve at work or at home, and then enter 1 or 2 steps how to achieve that goal. Give everybody a minute, and if somebody is daring to unmute themselves and speak up, that would be certainly appreciated as well. Instructions are clear? Okay, thanks, Angie. I will put myself in here. So I put myself. So Yvonne, yeah, I think Yvonne and I, we are aligned. We were sitting too much with all the COVID around us. So we have the exercise. So maybe what we should do is use an exercise example. Engage clients. Don't forget to maybe put in 1 or 2 steps how to accomplish this, so we better engage our clients. We're lovely to hear what are 1 or 2 action steps you think you can take to accomplish this. I think we all need a little bit more exercise, given that the chat room. Okay. Keep typing along, because what we are actually doing here is building the grid for a driver diagram, all right? First was the question, what do I want to improve? Which is the question of an aim. And secondly, how do I get there? Which is basically the action steps, or we call them driver. What are the influencers that will help us to achieve my goal? And so we have here, I see here from our Hope to Health, they want to engage more client or better engage more our clients. And one of the same was the closed loop processes. And I see here from Cole related to that is using a dashboard and weekly rounds. So that is basically in its essence what a driver diagram is all about. You establish a goal and then work towards its accomplishment, and you build a theory of change. So what the important part here is that in order to make a change or to see any improvement, you have to change something, right? And as this cartoon would say, well, what about if you don't change anything? Will something magical has to happen? Well, the magical thing is that you have to start out with any improvement, what you want to accomplish. What are my aim? What are my goals? But then we know that the ultimate outcome is improved process, improved outcome. I lost weight, I exercise more, right? But in between is my theory of change. It's the idea about what I believe will get me from my aim to my accomplishments or to my output and outcomes. And, and that's a really important idea. So we want to basically hypothesize what is my theory of change and what do I need to get done and what are my thoughts. What I see often when I visit programs virtually, obviously due to COVID, is they have an aim, they want to better improve, and they immediately jump to basically to solutions and immediately start implementing reminder calls, you know, but they don't necessarily have an underlying theory of change. We need to know before we start this journey of improvement, what do we want to accomplish and how do we get there, and really build this driver diagram. So there are two causal theory diagrams. We all probably, or many of you may be familiar with the fishbone. You see that here on your left, which basically is what the theory that the team has about the current process and what is the cause. In other words, in a fishbone diagram, I would write down what are the causes for poor engagement of our clients, right? So I would write this kind of outcome over here, and then it would brainstorm according to multiple variables or environmental factors, maybe staff, maybe resources, and then start brainstorming and put it on here on this fishbone diagram. Many of you may have done this before, and I know that you had sessions about this before. What a driver diagram does, in contrary to that, is what will result in the outcome. So in our case, we will draw here what is our aim. I want to actively engage or better engage my clients, right? And then I will basically end up, what do I need to do and how do I get to this goal by identifying the influencers, the drivers for those, for my aim. So think about as a driver diagram, basically as a flipped fishbone diagram, where I'm looking at with my driver diagram, what do I need to do? How can I build my theory of change? So this is also part where I think a driver diagram is really helpful. I'll give you a couple more ideas about this, is that there are so many things that you could do. But that's often not a very good start, just to start somewhere. Obviously, you want data, but you also want, what I mentioned many times already, is the theory of change. You want to build this kind of understanding, where can I put all my ideas? How can I organize my ideas so I don't end up like jumping around, but have a much better approach in taking that on that journey. Also, a driver diagram is also really helps me to visualize. It's a very visual tool and helps me to convince others and inform others about what we're about to do. So I wanted to be sure that this is really embedded in the model for improvement, the PDSA cycle that you're all very familiar with, all right? So the aim, which is our first question, usually comes with the model for improvement. What are we trying to accomplish is the aim, or in its essence, what the driver diagram would do is you establish here a measurable aim. I want to better engage, or our clinic wants to better engage our clients, right? And we want to make it measurable, we want to make it timed. So there's all the applicable rules for writing a aim statement we could apply here. Any measure that you relate to the aim is probably an outcome measure, right? And then I would think about, okay, if I want to better engage my clients, what would influence that? And then I would write this out here, and there's probably not more, there's not, here is just listed one, but there may be multiple drivers. And then off that, I would then think about what are the actual interventions that I need to do. Quick example, let's use the one of engagement, right? I would say, I want to better engage. I will come up with a measure. Then I would think like, well, if I want to better engage, one of the driver is, that the clients are fully aware of upcoming touch points with the clinic, right? So that would be a driver, so that the patient is aware how to be engaged. The second one is, for instance, second driver could be that the staff and the clinic is ready for patients to be engaged. So that would be, for instance, my two. Then the change related to the first one, that the patient is aware how to engage. That could be sharing of contact information, that reminder calls, things of that nature. And the staff-driven driver would then, for instance, be one change could be that there's a staff training about how about culture sensitivity, about how to let the patient know in the most appropriate way how to better engage with the clinic. Here's a very simple example. I want to start simple. So this is a one. So my in the most basic way, here's my baby sleeps through the night, right? So that is my aim. I measure this by my measurable outcome could be in the next 10 nights, how many nights did the baby sleep through the night? And then we can say, okay, that means like, I don't know, 80% sleep. So that would be my outcome measure. Here are the two drivers, right? The first one is that I want to minimize awakenings. So that will be my primary driver, and it could be one of many, but here are the two that I just want to make it very simple. And the second one we brainstormed with my team about is to say, okay, teach the baby to soothe him or herself if she awakens. So those will be influencers to actually get my baby to sleep through the night. So here, the next layer in my driver diagram is the changes that I will need to test. And so I can first, let's brainstorm as a group about how we can minimize awakening, and then we could come up with, well, use dim lights rather than, have a different setting. So I go out and buy a dimmer. And there could be all kinds of interventions that I can test out, but they're all related to this, to basically minimize awakening. And I would do this you probably want to have like maybe 3 to 4 primary drivers before you brainstorm on the changes to be tested. So why do we want to do this, right? Because we want to do this that basically you have an aim and you're not going out in too many directions. You build a theory of change. Our theory of change here means in order to accomplish my aim, I have to first think about what can we do to minimize awakening and how can I teach the baby to help him or herself to basically deal with the emotion of awakening and whatnot. So that's my theory of change. If I do those two things, I'll go to here. And then this could be my secondary driver. I know now that by doing this step will influence awakening, and then that will ultimately reach the goal. I departmentalize and basically brainstorm further. So why do I want to do a driver diagram? And many of the reasons I mentioned already earlier, right? One, it's a very visual tool. It helps me to set priorities. One of the things that we sometimes have done is not only to brainstorm, but also use data to support which of those drivers are more likely to be successful, right? But it helps me to set priorities. It also helps me to identify, what's my biggest impact. I can set measures that will be more likely to be process measures for each of the primary and secondary drivers. And I think what this ultimately will help me is to figure out what are the change ideas that I really want to try out. And it breaks it down in a way that makes it a more consistent and more precise about what I want to accomplish. Again, we differentiate usually. This is a different way of looking at it. It's basically the primary driver and the secondary. The primary driver is always like, what are the major categories? And the secondary drivers either could be another influences related to primary drivers, or then you can also add in the actual change ideas. Change idea could be a step taken by the staff or by the patient that can be tested out. A reminder, setting reminder calls, setting up a peer to deal with engagement of new clients. So that will be an intervention. Consistent messaging, meaning I remind clients that they or patients to come back to the clinic is an intervention as it relates to a secondary and primary driver. This is just a more theoretical display of something that was published several years ago, just to show. The reason I want to include it is that a primary or secondary driver change idea doesn't have to fit exactly into one. It may be overlapping. So by connecting your change idea or secondary driver, you can certainly make many more links, because often it doesn't fit precisely into one box. So before we actually gonna do one together, we're gonna do a practice round. How does this all sound to you? How is everybody doing? Does it make sense to you? And I want to hear a little bit about, Yvonne gives me a thumbs up, okay. And can you see already this being used in your clinic? Maybe one of you can unmute themselves and give me a reaction to what you're thinking so far about its usability and applicability to your program for using quality improvement.
Okay.
Go ahead, Yvonne.
Start us. We have staff meetings every couple weeks, and there's fun, but not a lot of organization or creation of like a visual you can come back to. So I can see this being really useful during our staff meetings and breakouts, and I think it'll help everybody feel like they can contribute in, just a little bit at least.
Mm-hmm.
Yeah.
Yvonne, I like the idea of democratizing the inputs, where everybody has a say. It also helps you to organize the many ideas that may be generated, right? But keep in mind, we don't want to start with, we're going to show this in the exercise, we don't want to start with what are all the possible interventions. It's more about to start out, what are the first drivers that would influence it? So you want to build it from the left rather than building from the right, or because otherwise we end up with brainstorming 100 ideas, and then we have to build it backwards. But we really want to do is, okay, if we want to better engage, what are the first drivers? What are the categories? And then be more detailed from that end. Let's hear from somebody else about applicability. Does it make sense to you? Any initial reactions? I think I will go with the 30-second rule here. So Sharon, go ahead.
Yeah, I think for me, what we've experienced with driver diagrams or fishbone actually is it allows us to shift from that initial, like, not complaining, but like everybody needs to debrief about the stuff that's driving you crazy. But then this allows for you to kind of move towards being more solution focused, look at what's in your scope of influence and what have you. So it prevents the meeting from getting stuck in just complaining, which I've been stuck in many times. So yeah, this is a tool to help kind of move that dialogue.
You're on mute, Clemens.
Yeah. It was interesting, Sharon, I want to echo what you just said, is about that. My first QI project I ever did, we brainstormed what can be wrong with this financial system as part of a big hospital. It took us like 2 months, and the list grew every time we met, where we never thought about what we can do differently. So in that sense, I feel like that you end up often with a cause and effect, like the fishbone that way, because we want to brainstorm what's wrong. Where I think if you flip the coin with driver diagram, it's often hopefully a very hopeful idea. What can we do differently? And when somebody says, well, that's wrong with it, it's like, what can we do differently? What do you think is, how can we make a difference to your system and make your work more enjoyable and joyful? Anybody else?
We have a question.
Go ahead.
Hi. I just have a quick question about creating the diagram. because I'm thinking, how much do you balance everyone thinking creatively and coming up with specialized solutions versus going into the research? I'm thinking about, if I was looking at someone whose baby wasn't sleeping well, one thing might be to brainstorm all these different ideas, but one thing might be to go to, okay, so what do we know about babies and sleep, right? What does the research show, and how do we balance what the research shows with what works specifically for our clinic or our problem?
Great question. Thank you. So clearly you want to use, evidence. You want to use what's out there. You want to start with what the staff and the providers are telling you, right? Because if I tell the research told you that, then everyone said, okay, let's go with the research, but it may not be relevant and locally applicable to what you try to do. And the other thing was, don't make the perfect the enemy of the good. In other words, if I say, let's look at the research and find everything, I guarantee you, Cole, Sharon, and Valeria and I, 3 months later, we'll still look at the research and try, we'll never start anywhere. So sometimes I come from the school where I want to be as helpful as possible. But sometimes when I hear from a clinically trained person who is maybe not the most convinced about quantum improvement, says, oh, we need more research, it's most likely and could be interpreted in my head, oh, there may be a resistance kind of a direction, which I know that you didn't say, but let's be hands-on. Let's try to come up with what the group can come up with. And I would usually say, let's come up with what we can do today and then support with the research to add things that we didn't think about at the time.
Yeah, and Clemens, I'd just add to that, you can think of the driver diagram as having several functions, and it's just one QI tool in your toolkit. So there are other ways to come up with change ideas, including looking at the research, looking at change packages from previous QI projects, brainstorming, all of that. But then those change ideas you get from various places, hopefully you can map them on to your driver diagram.
Any other questions? Think it more through the lens about how can I apply it, all right? And if you have any questions, we're going to do one together now, and I will show you several versions of very complex ones, one related to substance use, but I want to be sure we answer any questions that you have at this point. The other option is also, if you don't mind putting your question in the chat room, that's another way to quickly post any questions. Okay, so let's continue with our slides. So let's create one, all right? So that means this is a activity together. So most likely be on the unmute button close by. So I'm suggesting the following is to do something with active lifestyle, or that could be exercise, it could be any, I'm thinking more about COVID and we all sit way too many hours in a chair. So anybody wants to help me out with, and I'm going to take down the slides. Oops, I shouldn't have pressed this button. I'm actually going to type this in here and we're actually going to fill one out. And let me just make this big as possible. Okay, so the goal, the overarching is to have a more active lifestyle. So what would be my primary aim here? What can I type in here for this example?
So Yvonne says go outside more, but she wonders if that's too general.
I think that's, how about for the primary, if we want to basically state what's basically our overarching, right? So in this case, I would say probably to be more active, and then we need to decide what that means, right? Or to have a more active lifestyle, but the question is, how do we define that, right? It's maybe too complicated. How about we make it a bit more to lose weight?
Clemens, are you typing right now into the slide? I don't see anything. I don't know if it's just me.
I don't see it either.
Yeah, I don't either.
Okay, let me just stop quickly and then share again. Do you see my slide with the typing?
Not yet. It says it's starting to share.
Okay.
It's all black, and I wonder if it's
Yeah, give me,
frozen.
if we can wait about 30 seconds. So I typed something in the room, I mean, in the space here. So I said, my primary aim is to improve my active lifestyle to measurably lose weight. So that's my goal, right? And then I can be in my outcome measure. I could say, I want to lose, I don't know, 5 kilograms, 10 pounds, but in 5 weeks. So that would be my ultimate aim. Angie or Valeria, because I can see on my, if you give me a thumbs up once you see the slide, that would be appreciated.
It still says that it started, you've started screen sharing, but it's still a black screen.
Okay. Okay. Let me think about doing this a little bit different. Let me go in a Word document here. Sorry for that. It worked before when we tested it. Okay. Okay. Let's do this a little bit differently. Sorry for that. Let me go back here. You don't, if somebody can tell me, unmute and tell me when you see something other than the black box.
Still the same screen, weirdly.
Did you want me to share and then you can annotate or?
Yeah, that would be great.
Okay,
If you can
yeah.
go to the slide number 17, which it basically says, let me just stop sharing. It's the one that is basically an empty kind of driver diagram.
Okay.
And then we can fill out together. And I don't know if Angie or Valerie, if you don't mind, like actually physically type in, I can certainly help you what the words could be.
Okay, can you see my screen?
Yeah.
Great. So maybe, so what we can do here, when we say primary outcome or primary aim, how about if you type in, and that's just for my end, is to say, to improve my active lifestyle by measurably losing weight, or so that would be my very concrete, and then as an outcome measure.
Sorry, so can you say that again? To improve my
Absolutely,
active lifestyle?
improve my active lifestyle by measurably losing weight. And then in the outcome measure, we can determine that. So Cole, how much weight do you want to lose in 2 months?
10 pounds.
10 pounds, okay. The outcome measures then is to lose 10 pounds within 2 months. Or, so that's my overarching project I'm working on. So it would be helpful if potentially if you can unmute your line. So what will be our primary drivers here? So what are the things we need to do? What are the influencers to actually lose weight? Just shout out.
Regular
Maybe
exercise?
adding a regular exercise regimen.
Okay, so that would be regular exercise. So that could be the first one in the, okay, let's hear a few more.
Improve diet and improve sleep.
Okay, so the second one could be to improve my nutrition, or reduce calorie intake, for instance. The third one is, I think you mentioned that, is to improve sleeping pattern. Okay. Do we have one more?
I'm thinking something about like scheduling, making sure you have enough time in your day to focus on this stuff.
Okay.
Something.
Something about mind and body, or so something about how can we put this in a 2-3 words called?
Planning time, maybe?
Say it again, sorry.
Planning time, like I'm thinking when you spend some time to plan your week and how to,
Okay.
when you're going to schedule all this in and meal prep and that sort of thing.
Okay. Okay. Does it relate to basically losing weight? How about plan for meditation or something like that? You know, where it's basically, it helps me to the body-mind kind of connection.
So plan for meditation.
Yeah, for instance. Sorry, I put words in your mouth here, Cole. Okay, so let's take the first one, right? So let's be coming back to the regular exercise, right? So the question, the first is, what can we do about increasing regular exercise? So give me a few ideas. Don't forget to unmute.
Join a gym?
Renew my gym membership. That would be maybe the first one. What else?
Walk or cycle to work.
That is a great one.
Find something you enjoy doing.
Okay.
I read your mind.
Okay. So you get the idea. So we're going to go to the next one. There are many more ideas that we can brainstorm, but let's go to the next one, which is reduce calorie intake, and it will go on so on and so forth. But you see the difference now. So how can we reduce our calorie intake? What will be some of the influences to get there?
Start counting them.
Okay.
Planning our meals.
Can you say it one more time? Sorry.
Planning meals.
Okay.
Replace your high carb snacks with high fat snacks.
Okay.
Replace snacks.
Okay. So now you got the idea. So we have our primary aim. We have our primary drivers. And in our case, we have 4. And then we start thinking about what would you in this case do? You can draw arrows from your new gym membership. You will go to regular exercise. In our case, would be 3 arrows here. It could also be that Renew gym membership has also, because they have a meditation exercise. And so I could also draw, which we're not going to do now, but you can also draw, for instance, if that's the case, draw from here all the way to meditation, if that's it. So what you do next is you would think about, so how do I actually get to renew my membership? So you would then even take a step further and say, what are the action steps I need to take? Or renew membership is, you know, to basically pick up the phone and to call and use my credit card. I mean, we don't have to write it down now, but they would be basically the next layer. So what we have, go ahead.
Clemens, Joe had a good question in the chat. She was saying, how would we measure this if we wanted to focus more on health than weight? And she felt that weight might not be a good measure for this because it doesn't necessarily track the outcome exactly. Could we track fitness levels, endurance, other things? So I replied to her, I thought it might be the right outcome measure for some people, but not applicable to everyone. And I think the lesson from that is that the outcome measure is really context dependent and up to the QI team, up to the people actually doing the quality improvement work. So you pick a measure that seems to fit well for you, and it might not be generalizable to everyone.
Thank you, Cole. And thank you for the questions. Yeah, so first of all, there are many different ways how you get there, right? And so I think it's driven up, you always want to start out, what is my aim here, right? If my aim is to do more exercise, or if my aim is to, so there's so many different, or a healthier lifestyle that could be more focusing on different aspects. So you really want to be sure at the very beginning, as you do with a flow chart or anything like, you want to spend a lot of time thinking about what do we want to accomplish here? And because sometimes when you, like what the question suggests here, that we want to be sure everybody bought into the aim, everybody understands what the aim is, because then the discussion would be much easier going down the path. Okay. Do you mind going to the next slide? And probably we can go in slide mode just to make it a little bit easier, more readable. So I just filled one out, similar, just in case we didn't have enough time or we got lots of questions.
Are you seeing the speaking notes or presenter mode?
We see your
It's a
notes.
speaker
We
note.
see the speaking notes.
Okay, let me just swap this.
Perfect.
Is that
Thank you.
better? I just have a comment. I don't know if you're going to touch on this, but perhaps you can if there's time. I think this is really helpful, and it gives teams a good idea of where to start. If you have a couple of minutes, it might be helpful to use one example to show how we would actually start actioning this, whether it's running a PDSA or some of these seem pretty straightforward where you just do it. Do you have a moment just to speak to that?
Okay. So in this case, this is a pretty not simple, but more like straightforward example. I will show you one very quickly that's related to substance use where it gets complicated very quickly. But in this case, how about I will take that one when we talk about the substance use driver diagram. I think that would be a more logical way to spend our time, if that's okay. Next slide, please. So how do I do one, right? So if you think about, we had earlier, we heard, I think it was Ivan who would talk about, oh, that would be great for a staff meeting. So what you want to do first step is you always want to spend a lot of time thinking about the overall aim, or come up with it and really be very as precise as possible. It is not just like, here's the aim, let's go with it. What does everybody think? Do you need to triangulate and to be sure everybody buys in? Then you want to think about 2 to 4 primary drivers, right? What are the influencers that will get you there? And then once you identify and prioritize and come up with, here's my 2 to 4, at that point you take the first one and then brainstorm, as we did, with the first primary driver. How can we accomplish that? And then so on and so forth. And then the last step would be that you think about, when you have your secondary drivers, to think about the actual interventions that will help us to accomplish this, right? And that's maybe what I heard earlier from, what are some of the evidence-informed interventions, maybe some emerging practices that we can use to accomplish this. If you go next slide. Okay, so this is the next slide. You will see a substance use driver diagram that was developed with a group here in the US. If you can go to the next slide, that would be appreciated. So this is probably a little bit hard to read, so I'm gonna quickly paraphrase. There's a few verbiage in here that may be very US centric. One is that here is the goal, that a HIV clinic wants to end disparities measured by viral suppression rates for populations due to substance use. And we further can define it by substance use disorder. So the goal is, how can we, as our aim, basically increase viral suppression rate for those that are facing substance use disorders. So that is the aim. There's a specific measure in place, but that didn't fit on the slide. So the 3 primary drivers, that was the consensus of a national group, actually Cole was part of it, that we did this was that there are 3 primary drivers that were prioritized by the group. One was that the clinic track substance use status and health outcomes for all clients. The second driver that was identified here is that the clinic and care team is fully prepared to care and support clients with substance use and or mental health concerns. And lastly, that clients are successfully linked with relevant services and support to reduce harm caused by use of substances and or mental health concerns. So we broke this down. The reason why I think the driver diagram is worth its investment of time is because you can break down a very complex issue into things that we can communicate and visually share with others. So then what we did was we took the first one, the first primary driver, and then discussed a little bit further about the secondary. I'm reading a few because it may be hard for some of you to actually read it out. So the first one that was related to the clinic tracks substance use status and health outcomes. The secondary driver here is ongoing engagement in HIV care ensures clients are comfortable discussing use of substances. procedures in place for regular screening and documenting client use of substances. The care team understands the signs of substance use that could cause a barrier to viral suppression. And the fourth one here is procedures in place to review substance use outcome reports and take action if indicated. And lastly is here for the first driver is indicated definitions are well established to track health outcomes for clients with substance use disorders and or no substance use status. So in other words, we broke down in further steps. And so we obviously, I won't read the rest, but you get the sense of that it breaks this kind of a colossal idea into further snippets. And so what we then did, we looked at the secondary drivers and we looked around and discussed with people. So what emerging practices, basically where we didn't have enough data, or interventions that were based on evidence, either they are published or they had data to support them. And then we identified interventions related to some of the secondary drivers. Some we could not find, but some we were able to do. So we identified in our case, and I can share with you the website where you can actually find the driver diagrams and the interventions, where we'll be able to actually pinpoint. So the next chart on this one, which I didn't do because then the fonts gets even smaller, go to the right of the secondary driver, there will be the list of interventions that we identified. In this case, we identified about 15 of them, and then made marks or made basically connectors, lines connect them with the actual secondary intervention that we think. So let's say there was a peer interventions, basically where peers were hired to communicate with people to help them to engage to substance use assessment. So that was the intervention, was proven to be successful. And then that was one intervention, and then we linked it to some of those. So I'm gonna stop here. Does it all make sense to you? Cole, anything you wanna add to this one?
Nope, that was a great overview.
Okay. So I would also love, I'm gonna show you one more and then we're gonna take the slides down. I wanna have a little bit more discussion. So the next thing I wanna show you is to even more complicated. This is too small to go through, but this was basically the question about that we wanted to brainstorm about how can we address racism, particularly towards Black African Americans in HIV clinics. Incredibly complex, incredibly societal change. Many of the things an HIV clinic or a substance use program cannot influence. But again, we went through the same process, or we tried to figure out what are the primary drivers, what are the secondary drivers, and we went through the same process. And what I find, why, if it's a very simple project, I may do this driver diagram within an hour very quickly with a group. But if I really have it is worthwhile the investment of time, particularly when the issue is very complex. The more complex the problem, the more likely you want to do a driver diagram. Okay, Valeria, do you mind taking down the slides for a minute?
Yeah, my toolbar is gone. I don't know. Angie,
Okay.
can you kick me off somehow?
I just kicked you
Yeah,
off.
there. Okay,
I didn't
thanks.
want to do it. So I'm going to stop here. Any questions, thoughts, ideas? And Sharon or others, if you have any other thoughts, ideas about driver diagrams, we would love to hear from you. Yvonne, what do you think? Can you do, when your next staff meeting, do you think you would be able to do it? Because you mentioned that earlier when we started.
I think so. I feel like this is one of those things that you want to put up on the whiteboard and put a please leave on sign up there, because there's a lot there and you want to be walking by it every day and kind of revisiting it in your mind every day. Yeah, I think the visual is really helpful, but there's a huge risk of you do all this great work and then everybody says they go off to do the things, but it's not like there. So I just think like keeping it there in front of us is going to be really important for its success.
Great idea.
What about updating it periodically? Did you talk about that?
Do you want to share your thoughts, Cole?
Yeah, it's one of these things that I think should be a living document, right? That your team periodically goes back to and says, okay, is this still accurate? Are we missing anything? I think a great example of that is if we had a boost driver diagram before COVID and during COVID, it'd probably look a lot different during COVID.
That's a great example.
Yeah, I was just going to say that's interesting. I haven't really thought about, you can kind of think about driver diagrams as doing it in like an hour meeting or something like that and trying to work through and come up with those change ideas, but thinking about it more as like a living, thing that you kind of go back to and revisit over time. That's an interesting way to think about it. It's a good point.
Yeah, I agree with Yvonne, especially with the part about keeping it up, because I think you're right. It can be a nice, pretty digital version saved somewhere, but sometimes that visual reminder in the clinic space is good to keep us on check and to look at it and say, hey, maybe it's time to revisit this, or, yeah, we said we were going to do this idea. We didn't get to that one. So I agree. That's a good point.
And when you're testing your change ideas that are on the right side, if some of them actually don't work, then you can just prune them off of your diagram too.
I like the idea of prioritizing some of the secondary drivers and, maybe just keeping the rest, even like having a jar of drivers for whatever you're working on. And when you've run out of ones that you've tried, you can just stick new ones up because if you need to, right? And I think that really helps everybody's ideas be valued, like physical sense even. I'm having flashbacks to grade school where you like put ideas up with the little Velcro things, and that's what I want to do now.
Another thing I'm thinking is, Clemens, you mentioned a bit about how measures might fit on there. I don't know if you want to expand on that a bit. Like, how would I link my measurement plan to the driver diagram?
Yeah, so I think that first you need one measure that's your overarching, that's your outcome measure where you want to really be sure that you can routinely measure it. And I think particularly when you think about the secondary drivers as well as the intervention that will follow, you really want to be sure that you have measures in place, right? So one intervention could be reminder calls. I'm making something very basic. You want to be sure that whether or not that intervention works. The fact that the evidence for reminder calls or for the intervention of choice is working doesn't mean that it works at your clinic, right? So you have to apply that. So you want to have a measure in place that you actually do so. And then basically do the same PDSA cycle that you have done for a long time, or test it out on a small scale, see whether it works, and expand and make adoptions and adaptations to it so that you can learn from that experience.
So one thing I'm thinking, anybody on the call, if they're thinking they're going to go away and do a driver diagram in the next little while, it'd be cool to bring it back the next time we have one of these calls to see what people have done. I'm working on one with the Hope to Help team, and it's just very big and unwieldy right now, and our next step is to prune it down, but I'll bring that back and share it next time.
Karen and myself, we're working with the SCS team at the Hope to Health, so we're planning on doing this with the team coming up. We're going to introduce a few tools, including the driver diagram and the fishbone. So if we do get to that before our next session and we've developed something, we'll bring it back and show the group. So we'll see how that goes. I think this has been really helpful today because, I know a little bit about a driver diagram, but I think, it comes with practice using it too. So, hopefully we'll be able to do that with the team, and it's going to help us a little bit to focus kind of our work, what we're going to be doing.
I want to, before we're trying to come up with this, pull up the slides one more time, I think two things that Yvonne and others mentioned is the accountability for the driver diagram, or this is just a tool. The fact that it's the prettiest tool in the background, it is really, it's the action that you take after you complete the driver diagram that really counts. And it can be the prettiest one. So that's why I think that everybody's point that the accountability is really key here. And Yvonne's idea is just to leave it up there so that every time I walk by, oh, did we do this one thing? That I think is a constant reminder. And I think the other thing that you mentioned I want to say is the prioritization. The fact that you have 25 secondary drivers does not mean that you need to do 25 things. It means that you brainstorm as a group. This is our theory of change. This, in the ideal world, if you do everything, then we can have a really measurable impact. The reality, however, is you need to figure out what's the 1, 2, 3, 4 interventions that you should do. But it helps you to connect it. If you come up with a great idea, you saw it in the Lancet article, New England Journal of Medicine, but it doesn't fit into your anywhere on the driver diagram, it may still be a great intervention, but it didn't fit in the clinic's way of doing it. So then that intervention may not be the right one for you. So you always need to link that through. Ideally, you can figure out what are the 2, 3 things, prioritize, and then document it. And the theory of change will then still hold up. Cole, do you want to add anything to that?
Well, when you mentioned accountability, and I keep thinking of Yvonne's, Velcro and the big thing on the wall, you could get pictures of your staff and put them beside the things they're accountable for. Or maybe the avatar versions of them or something.
So we have two more slides, I think. One is that it's just a resource slides, and I will try this on my end. I try one more time and then I give up. Can you see the slide? Okay, good. So there's some resources. There are really cool resources out there. I put 2 of them in the chat. Those are things that we actually developed. One is specific to substance use, not necessarily opioid only, but there's a high relevance. And then the last thing I want to do is aha moments. So I want to hear from some of you. What is the one thing that you learned? So what was the aha moment, big or small? If you can quickly unmute. And who wants to get started?
I'll start.
Okay.
I think the key thing I learned is that I wasn't really going far enough, breaking it down, kind of stopping at drivers, thinking, okay, yeah, I'll just exercise more, whatever, just do it, right?
Mm-hmm.
So just breaking it down more and knowing that even after secondary drivers, you might want to look at breaking that down and just chip away at it, right? This doesn't like flip the lens, but it just makes everything into bite-sized pieces, which makes it less intimidating for people.
Thank you for sharing. Anybody else?
I would agree with Yvonne. I think, the active lifestyle example we've heard before, and I think sometimes we underestimate that it should be thought of as a big attempt or big aim, right? Like trying to become more active or lose weight or whatever it is. It's not as simple as like, okay, I'm just going to exercise more. There's a number of factors. So it gives us a good example of how something that we often think is simple to do isn't. And then when we're looking at it in our work setting, it also gives us that same lens. How do we break this down and into small steps, and what are those specific drivers, and then how do we do those things, and then reassess things and what's working and what's not.
I agree with that also.
Thanks, Darcy. Anybody else?
I think for me, it was just looking at it as, like we talked about, as a living thing that you can come back to, not just, going through the process and then, once you're kind of done leaving it at that, you can revisit it. And because, things obviously will change over time. So yeah, coming back to it.
Anybody else?
I just wanted to quickly note, we've dropped a link in the chat, as we always do, just for a quick survey. It shouldn't take too long. Don't feel the need to, even fill out all the questions, but it'd really be great to hear your feedback on like future topics for these sessions, which are kind of aimed more at QI. So yeah, just if any of you can complete that survey, it'd be greatly appreciated.
Also, top of the hour, so I wanted to thank everybody. The slides are available, so if you want to use them, and also I'm putting my email address in the chat room. So if you have any questions, follow up, any resources that I was talking about, but they're not in the slides, then I'm happy to follow up with you afterwards. With that,
so we'll set aside 10 or 15 minutes at the start of our next Boost QI session to see what people have and have some time to share and maybe do some advising or consulting for each other. And maybe we'll email people about a week before to remind people of that opportunity.
Yeah, that's a good idea. Hopefully we'll see some interesting examples.
So look out for an email, but we will send something out. I believe the next date will be in May. April 20th is our regular Boost webinar. And thank you again, Clemens, for joining us today. It was great to have you back and see a familiar face, someone that's also familiar with our work. It was very helpful to have you walk us through the driver diagram. It's certainly not a new tool to everyone, but it's always great to hear it from someone else in a different way. So that was extremely helpful. Thanks everyone for taking time to join us today. I know it's a busy time of day and busy time of year, so we appreciate it. Like we mentioned earlier, we'll send out a listserv once this is available on the website, and you can share it with anyone that wasn't able to attend. And like I mentioned in the chat, if anyone is looking to undertake this task of creating a driver diagram with your team and you'd like some support with that, reach out to us. We'd be happy to connect and perhaps even join your meeting to support that if that's something you're interested in.
Yeah.
Have a good day, everyone.
everyone.
Thank you, everyone.
Bye, everyone.